Okay, welcome everybody. Thank you for joining us. Good afternoon. Welcome to Sports Concussions, What You Need to Know. My name is Deborah Holloway, and I'm Education and Resource Coordinator at the Brain Injury Association of Virginia. And this webinar is being hosted by the Brain Injury Association of Virginia and the Virginia Department for Aging and Rehab Services. And this project is supported by the Health Resource and Services Administration of the U.S. Department of Health and Human Services. And just real quick before we get started, I wanted to do a few housekeeping items. Notice everyone's muted. We are going to record this webinar and be able to share it with others that can take advantage of this wonderful opportunity. And if you have questions throughout the webinar, please use the chat box and chat your questions. And then at the end of the presentation, our presenters will address the questions as time allows. We also will be sending a survey out, and that will allow you to ask a question when you complete the survey if we don't get to your question. Okay. So now I'm going to introduce our presenters. Our presenters today, Dr. Donna Broshek. She's an associate professor in the Psychiatry and Neurobehavioral Sciences and co-director of the Brain Injury and Sports Concussion Institute and Neurocognitive Assessment Lab at the University of Virginia. Dr. Broshek has been a consultant to UVA athletics teams since 2000 and is president-elect of the Sports Neuropsychology Society. Dr. Shane Caswell is a professor of athletic training at George Mason University and founding executive director of the Sports Medicine Assessment Research and Testing Laboratory. Dr. Caswell actively works with numerous youth leagues and school systems on the prevention, recognition, and management of concussion in athletes. And Dr. Howard Goodkin is the Scher Professor of Neurology and Pediatrics and the Director of the Division of Pediatric Neurology at the University of Virginia. Dr. Goodkin serves as a neurological consultant to the UVA athletic teams and has been part of the Brain Injury and Sports Concussion Institute at the University of Virginia for 13 years. Thank you guys so much for joining us. There's our contact information at the Brain Injury Association of Virginia and the Virginia Department of Rehab Services if you have questions after this presentation or need to get in touch with us for resources. And I'm going to turn it over to our presenters.
Thank you so much, Deborah. We really appreciate this opportunity to present this webinar. And we understand that many of those attending this webinar are school personnel, so we are particularly pleased to be able to get this information directly to you. The outline is showing what we're going to talk today. We're going to talk a little bit about the concussion basics and the Virginia state law. Dr. Caswell is going to spend some time talking about on-the-field assessment of sports-related concussions. We'll address classroom issues in returning to learn. And then returning to physical activity and competition. And Dr. Goodkin will talk about managing headaches after concussion, which is a particularly problematic symptom, and the role of exercise in prolonged recovery. We'll also field some of your questions. And as Deborah mentioned, if there are some questions that we don't get to, she'll send those to us, and we'd certainly still be happy to answer those questions via email or another mechanism. So we're going to start by talking about what is a concussion, and this is a fairly recent definition, but I think it really does a nice job of explaining what happens. So a concussion is a pathophysiological process, and what that means is that we're not talking about damage to structures of the brain, but more of how the brain functions. And so it certainly affects the brain, and it's induced by a traumatic biomechanical force. And another key concept here is that this force can be caused by a direct blow to the head, but many times in sports the blow might be to the chest or to the torso, causing the head to sort of have a whiplash mechanism which transmit forces to the head, causing the concussion. Typically there is a rapid onset of short-lived neurologic symptoms, and these resolve spontaneously. However, the resolution may take days to weeks, and in some cases the symptoms and signs may evolve over minutes to hours. So there may be some initial confusion, and then some of the symptoms may get worse for a little period of time, but that's usually minutes to hours. So again, these symptoms typically represent a functional disturbance of the brain, and that's why when somebody does have a head CT after a concussion, it's typically negative because, again, the structures are not typically affected. Another key issue here is that a concussion does not necessarily involve a loss of consciousness. Certainly some do, but many concussions do not involve any kind of loss of consciousness, but more of an altered consciousness or lack of awareness. And these symptoms follow a sequential course, and we'll talk more about those symptoms. And a very small percent of individuals have a very prolonged post-concussion pattern where their symptoms persist. So if you look at this slide was actually created by Dr. Goodkin, and he very nicely separated out the symptoms into the various clusters. And one of the clusters are the somatic symptoms. So these are the physical symptoms of concussion. Includes headaches, nausea, difficulty with balance and coordination, a feeling of dizziness, and sensitivity to light and sound. Another core group of symptoms are those involving sleep. After a concussion, people may have difficulty falling asleep. Their sleep may be very fragmented or disrupted. They may sleep too much or too little. And this disturbance in sleep can contribute to the difficulty with thinking because sleep is so important to good cognitive functioning. There are also mood changes that can occur after concussion, and these can take the place or consist of irritability, but also emotional lability. So people may cry very easily or get angry very easily. Just sort of anything you feel, the brakes kind of come off, and you might feel things more quickly and more intensely. Reduced frustration tolerance is very common, and that's really having a short fuse. So things that might be normally mildly irritating can cause one to lose their temper. And then certainly some athletes experience sadness or depression or symptoms of anxiety. The cognitive symptoms include this feeling of fogginess, just sort of generally suppressed brain function, and cognitive fatigue, just feeling sort of like your brain is tired, like you don't quite have your usual horsepower. And then also difficulty with attention and memory deficits. So at the time of concussion, what typically is seen is a lack of awareness of surroundings and confusion. And if you look at the young man in this picture, you see that sort of vacant stare, and that's a very classic sign of concussion. Just sort of not being aware of where you are, not really processing information. Other common symptoms include nausea or vomiting, headache, memory problems, not knowing where you are, what game you're playing, dizziness and vertigo. And Dr. Caswell will talk a little bit more about how this young man would be assessed on the field. So this slide really shows that what happens at the time of a concussion is that there is a mismatch between the brain's demand for energy or glucose and the body's ability to deliver that fuel. So at the time of concussion, there's really a metabolic crisis, and the brain is needing more glucose, more energy to cope, but that energy is not able to be delivered. And so you can see that this creates a sort of energy crisis within the brain. And if you look at the slide, you can see that this pretty much resolves by day 9, 10. And we know from various research studies that have been done that in certainly college athletes, typically concussions resolve by about day 10. This really sort of nicely mirrors that. This is a very complicated slide, and the purpose of showing this one is to show you that at the time of a concussion, there's a lot going on at the cellular level. So again, we don't typically see structural deficits in the brain after a concussion, unlike more severe brain injury where there might be structural damage. But here it's at the cellular level, and again, it's essentially the brain is not able to produce energy, and there's a metabolic crisis. So as I mentioned, when we think about healthy college-age athletes having their first concussion, typically their symptoms recover within about 5 to 10 days, and that's a full recovery. However, kids generally take longer to recover, and some may take 30 days or more. So it's really important that we are more conservative in the management of younger athletes. We tend to hold them out longer because we really want to make sure that they've returned to their full baseline. The Lystet law is the first state law in the country to mandate sports concussion management for youth athletes. And you can see in the bottom corner of your screen a picture of Zach Lystet. He was a high school athlete and played football as well as some other sports. And he was playing in a high school football game and sustained a hit and had a concussion and was pulled off the field very briefly. He returned to play, and shortly thereafter he had another hit and he crumpled to the ground, and he had a very, very devastating injury. You can see him there in his wheelchair actually looking pretty healthy. He had months and months of rehab and a very, very serious injury. And he and his parents worked with the governor of Washington State to pass this law, which mandates that no student athlete can return to play, to their game, after a concussion until they've been evaluated and cleared by a healthcare professional. So this became the model for other laws across the country, and it's the model for the Virginia Senate Bill 652, which mandates concussion education in all public high schools for coaches, student athletes, and parents. It also mandates that there be policies and procedures for managing concussions. The student athletes and parents are to receive annual education, and the really key aspect here is that any athlete with a suspected concussion shall be removed from play or activity and shall not return the same day. If a concussion is suspected, they must be evaluated by a healthcare professional. And you can see here the healthcare professionals identified as providing this clearance, and that includes a physician, physician assistant, osteopath, athletic trainer, neuropsychologist, or nurse practitioner. The state law also mandates that prior to beginning a return to activity, they must have recovered. There must be symptom-free, and it requires written clearance for return to activity. So the healthcare professional who evaluates them must also provide written clearance. And the good news is that there is now a version of the Lystet law in all 50 states that protects youth athletes and mandates some kind of concussion management plan. So I'm going to turn it over to Dr. Caswell now. He's going to talk to you about assessing concussions on the field.
Thank you, Dr. Broshek, and hello everyone that's on the webinar today. My purpose today is to provide an overview of the process that a healthcare provider would use when assessing a concussion on the field, and often this is an athletic trainer. The best way to evaluate a concussion is continually evolving. There are two primary goals of a concussion on the field assessment, and first is to identify if there is a medical emergency that's occurring that requires immediate referral. The second is to prevent further harm. Regardless of who is conducting this evaluation, what healthcare provider, there are four key principles. First, there is an evaluation of symptoms and a history. There should be an assessment of balance. There should be an evaluation of cognitive functioning and memory, and then a neurological examination. The four most commonly used tools by healthcare professionals include the standardized assessment of concussions, symptom assessment scales, of which there are various types and models of symptoms assessment, and Dr. Goodkin can talk a little bit more about that later, the balance error scoring system, or the BESS, and the Sports Concussion Assessment Tool 3, or the SCAT-3, which pulls many of these aspects together. So when we're evaluating someone, oftentimes we begin with a set of questions that are designed to collect information regarding the short-term and short and intermediate-term memory functioning of the individual. So questions such as, where are we, what quarter is it right now, who scored in the last game or practice, who did we play in the last game, did we win or lose the last game? And these are called Maddox style questions when you see your practitioner doing these on the sideline. The next is the Standardized Assessment of Concussion, or the SAC. And this tool tests orientation, memory, and concentration, and it can be scored out of a total of 30 points. And it's important to identify that this tool, and all of these tools, in fact, are only a part of a sideline assessment. They do not function as standalone concussion evaluation tools. This particular tool assesses orientation, immediate memory, and concentration. Orientation is assessed through 5 questions, very similar to the Maddox scale. Immediate memory is assessed by 20 points, where individuals recite words such as elbow, apple, carpet, saddle, and bubble over 3 trials, and they're asked to recall those words over a period of time and assess on how many they can recall. And then concentration asks the individual to recite a sequence of 4 numbers in reverse order. And from that, we can come up with a score to help practitioners gauge whether or not someone is demonstrating symptoms of a concussion. It's commonly accepted that balance is often affected by concussion. And Dr. Kevin Guskowitz at the University of North Carolina developed the balance error scoring system, which tests balance and other common postural symptoms affected by concussion through having individuals stand in 3 different stances on both a solid and a soft surface with their eyes open and closed, and then we measure the number of errors that these individuals have, such as touching their foot to the floor, putting their hands on their hips, etc. And this gives us an understanding of how their balance is functioning. Most recently, in Zurich 2013, at the concussion conference, an international panel of world-renowned experts put together what they believe is the most recent version and best version of a concussion assessment on the sideline to date, which is the Sports Concussion Assessment Tool, or the SCAT-3. And this particular tool attempts to provide an objective standardized measure by pulling together the Maddox, the SAC, and the BESS, and is to be used by medical professionals, and there are 2 versions. One for individuals that are greater than 13 years of age, and another for individuals under the age of 12, or the child version of the SCAT-3. And as you'll see over on the right-hand side of the screen, there's a number of tools that the healthcare provider can use on the sideline to assess symptoms, to look at whether or not the individual may have suffered a spinal injury, to evaluate balance, coordination, to assess cognitive and physical evaluation, and then ultimately to provide a score. I think it's important here to say that regardless of the tool that is used, proper concussion assessment on the sideline needs to be performed by an appropriately trained healthcare provider, and it relies largely upon their best clinical judgment. So when they're evaluating these individuals on the sideline that they suspect of suffering a concussion, some elements would indicate that we should immediately refer these individuals on for greater care, and such as deteriorating mental status, a suspected spinal cord injury, any evidence of a potential skull fracture, if symptoms are progressively worsening or changing, such as a new headache, any unusual behaviors, if they seem confused or irritable, they cannot recognize people or places that they should, any weakness, numbness, or tingling, difficulty standing or walking if they seem unsteady, challenging difficulty speaking or understanding directions, any type of persistent nausea or vomiting, and seizures should be referred on immediately.
Okay, so now we're going to talk a little bit about returning students to academics after their concussion. So in a lot of talks, at this point, we progress to talking about returning students to activity, or to athletics and activity. But one of the key issues is that it is extremely important that students be returned to the classroom and able to function in the classroom before they're cleared to return to their sport. And if you think about it, if a student has had a concussion and they cannot sit in their classroom reading a book, they are certainly not ready to be back out on the soccer field or the football field. So with athletics and academics, it's really important to think about the kinds of symptoms that people have after a concussion. So if you think about having a headache, fatigue, dizziness, feeling sensitive to light and noise, not sleeping, and ringing in your ears, in addition to having trouble with attention, concentration, your memory not working as well as it does typically, processing information more slowly, and also completing tasks more slowly, and then imagine trying to be in the classroom. So during recovery, these students often need some temporary academic adjustments. And the critical issue here is to have an immediate period of rest, and that's typically 2 or 3 days, and they may actually need excused absences from school for a couple of days initially while they have the most acute symptoms. But then they'll need an individualized plan to balance work and respite from their symptoms. And we'll talk a little bit more about that on the next slide. And I also want to call your attention to the fact that students who have pre-existing learning disorders and or ADHD may have a more complicated recovery, and that's because they are already dealing with difficulty with attention or slowed cognitive processing speed or other academic issues. So when we think about academic adjustments, there are a lot of things that can be done on a temporary basis to aid the student athlete in returning to their academic schedule. So as I already mentioned, they need a brief period of rest with some initial excused absences, but then ideally we really do want to reintegrate them back into the schoolroom as efficiently as we can, but they may need some periods of rest while at school. And depending on the school, this may be, going to the nurse's office, and particularly if there's a physical education component, not having them participate in that, but maybe sitting quietly in the nurse's office that period. Some schools are able to use the library to allow the student to just sit quietly. And sometimes we recommend just a shorter day for a couple of days, maybe going in the morning if that's their better time, or arriving late and attending afternoon classes. It can be extremely helpful to relax some of their time demands. This may include giving them extra time on timed tests in the classroom, extending deadlines for various projects, and then staggering or delaying tests. Probably all of you have had the experience of having multiple tests at the same time, all on the same day or within the same week, and finding a way to work with the teachers to stagger these so the student can space them out can be very helpful. Another issue is having the student resume work but only do partial work. This may involve doing parts of homework assignments, allowing them exposure to course summaries and notes from the teacher. And another thing that can be very helpful is to allow them or have them take tests or quizzes, but reduce the value of those particular tests or quizzes that are happening while they're still symptomatic. Also, it can be very important to be mindful of the light and sound sensitivity. In modern classrooms, there are many smart boards and computer equipment, so reducing the background lighting on those can be very effective, as well as turning out overhead fluorescent lights, and minimizing exposure to loud sounds. So that may be excusing them from things like band and school assemblies. And Dr. Caswell is now going to talk about returning athletes to activity.
So one of the most challenging decisions that are made following concussion is, when is it safe for someone to return to play? And a lot of thought has gone into this and much research. One of the key tools that is used is a progressive return to play protocol, which you can see on your right-hand side of your screen. Regardless, the athlete must be asymptomatic at rest and with exertion, and be provided written clearance by an appropriately trained healthcare provider, listing that Dr. Broshek mentioned earlier in the presentation. And then the athlete must progress through all of these stages and being symptom-free throughout this progression prior to being returned to full non-medically supervised competition. I think it's also important to indicate here that they must complete full return to school activities prior to returning to play. and that is specifically identified in the latest edition of the Student Athlete Protection Act in Virginia. And so this is very much a teamed decision. Full return to all school activities first before returning to play. So the return to play progression can be affected by a number of factors, such as the previous history of concussion, duration and type, severity of symptoms, age and sex of the athlete, the sport activity in which they're participating, and then individual traits, such as any learning disorders or psychological factors that they may have. Regardless, the return to play decision should be a team decision with stakeholders from the school, the medical community, and home. And only after a complete resolution of all signs and symptoms should they begin the return to play progression. Regardless of medical clearance suggesting earlier return to play, the athletic trainer or healthcare provider on site should be monitoring this individual for the return of any signs and symptoms and making the decision whether or not this individual should be reevaluated or potentially rest. At this time, a symptom checklist can be very helpful for the athletic trainer or whoever is working with the athlete to be able to compare symptoms before and after exercise on a daily basis and document how these symptoms trend. I think we need to resist the tendency to minimize symptoms within our athletes and tell them to just suck it up. I think that we need to minimize that. We also should not hesitate to delay progress or even go back a stage. And throughout the return to play progression, because this is a team-based decision, it's very important that all stakeholders, teachers, administrators, parents, and the medical professionals continue to observe the patient's symptoms and meet as part of a concussion management team about that student.
So this is Dr. Howard Goodkin, and I again want to thank everybody for joining us today and sticking with us at least halfway through this webinar. As we already heard from Dr. Broshek, there are a number of symptoms soon after concussion. Dizziness, balance issues, fogginess, but of these, the one that is most common is headaches. And unfortunately, for some, headaches will persist long after the time period where we would expect somebody to get better. Indeed, headaches and many of these post-concussion syndrome symptoms can be present in a small minority of patients 3 months or longer. In terms of headaches, what predisposes someone to long-term headaches after a concussion has been evaluated by Dr. Heidi Bloom at the University of Washington. She looked at emergency department records from across the country of not only sports concussion, but all types of traumatic brain injury, moderate traumatic brain injury as well as severe traumatic brain injury. One thing that came out of her study was that injury severity made a difference in that those with sports concussion were more likely to still be complaining of a headache 3 months after the injury than were those with moderate or severe traumatic brain injury. Those with loss of consciousness or amnesia as part of their traumatic brain injury were more likely to still be complaining of a headache 3 months out. And as we've already heard, pre-morbid conditions really are very important on how you do after a concussion. Those with pre-traumatic headaches were likely to still be having headaches 3 months after the concussion. Those with a family history continue to complain of headaches 3 months out. And those with psychological issues such as ADHD were more likely to still be complaining of headaches 3 months after the injury. Age played an important part in that adolescents seemed to take longer to recover than did children. And gender was also another important factor, with girls more likely to have headaches 3 months after the injury than were boys. And some of these factors were still at play 12 months after, but the number of children still with headaches 12 months out were much less than at 3 months out. So headache is usually the reason that sends a child or an adolescent with a concussion to the neurologist. And as part of that assessment that I do, I certainly want to learn about the headaches, the frequency, the severity, the characteristics. Is it a pounding headache or a squeezing headache? And how's it been changing over time? As we've already learned, headaches are just one part of the entire post-concussion syndrome complex. So I started asking about vertigo, neck pain, sleep problems. How are they doing in school? How is their mood? I review for any stressors in the household or the school, and it's not uncommon to find many stressors in every adolescent's life. I'm very interested in fluid intake. I ask about drug or alcohol use, but as you know, those answers are always no. I don't do that type of stuff. I certainly ask about predisposing factors such as pre-injury headaches and pre-injury function. I take a very careful medication history. I want to know what they've been using to treat their headaches, because often what can happen is that we get into a withdrawal syndrome or medication overuse headaches, and the best thing I can do is ask them to stop the medications they've been using for their headaches. I ask about pre-injury headache and function I've previously mentioned, and I like to learn about family history. And then examination is critical to determine if there is anything that's concerning me as a long-term effect on their neurological function. We already heard from Dr. Caswell of those red flags that we look for soon after the injury has occurred, red flags that would make us want to have the child evaluated in an emergency department. Some of those red flags include altered mental status, papilledema, which is a swelling in the back of the eyes, abnormal eye movements, and asymmetries. By the time that most of the children arrive in my office, if they were to have any of these from their injury, these should be long gone. But I continue to look for these in case there's another factor at play for the headaches other than the concussion. I look for a progressive pattern of the headaches. Again, I'm trying to understand, is there something other than the concussion which may have led them to my office? I look for increased headaches with straining, coughing, or sneezing, which can at times indicate that there's a mass lesion or a tumor in the head. I ask about sleep-relatedness of their headaches. Headaches that awaken you at night, again, are a red flag to me that something other than concussion could be going on, as are explosive or sudden onset of severe headaches long after the trauma. And all of these are an indication to me that head imaging or an MRI may be necessary. But the important part that I want to emphasize here is that it is rare that head imaging is part of a concussion evaluation, even when they get to the neurologist. That, as Dr. Broshek mentioned, this is a functional injury brain, not a structural injury of the brain. So really, only in limited cases does head imaging play a role in the assessment of somebody who has a post-concussion syndrome. Treatments in the acute phase of the post-concussion headaches can include acetaminophen and non-steroidal anti-inflammatory drugs. Usually we ask people to avoid these in the first 24 hours because of the effect that they can have on platelet function and bleeding. Triptans, these are drugs that work on the serotonin system of the brain, which are very important for migraine headaches, can be used, although there are concerns for some that they actually may make the headache work. And dihydroergotamine is another drug that works on the serotonin system that can be used to help the person who's had prolonged headaches, although this requires hospital admission. Sometimes we place somebody who's had prolonged headaches after a concussion on a preventative or prophylactic medication. These include tricyclic antidepressants such as amitriptyline, two of the anti-seizure medications, valproate and topiramate, antihypertensives such as beta blockers. Some find that vitamin supplements such as magnesium, riboflavin, coenzyme Q10, as well as the root of the butterbur plant can be helpful for treating prolonged headaches after concussion. And then muscle relaxants actually do have a role, especially for those who present with ongoing whiplash-type injuries or cervicogenic headaches or muscle tension in their necks, which may be also the precipitant of the headaches. And also, as I already noted, that we need to be aware that when we use too much pain medication, we actually can make headaches worse and not better. Other treatments that we pursue when headaches are going on for too long after a concussion include physical therapy to regain neck mobility. We can use nerve blocks on the occipital nerves that travel through the neck and the back of the head, which sometimes can be injured during a concussion and lead to neuropathic pain. Psychotherapy and biofeedback certainly have a role in headache management not only after concussion, but everybody with chronic daily headaches to deal with stressors or to understand why the headaches persist. And then we'll also talk about a very important role of exercise in those who present with prolonged headaches. This is a study I'd like to highlight because it really emphasizes the importance of why we're all here today and the importance of knowledge and transporting that knowledge that you have about concussions to your students and to their parents. This was a study in which they compared those who received an information booklet about what to expect after a concussion and a one-week visit with the concussion team compared to those who were basically sent off and told to deal with their concussion. And not surprisingly, those who were informed, those who had contact with the healthcare provider did much better, and their headaches were better, their irritability was better, judgment was better, and sleeping difficulty was better, just with the simple intervention of receiving an information booklet and having contact with somebody educated in concussions. So we can make headaches better just by informing people of what to expect after the injury has occurred. So I'm going to turn emphasis right now and go back to this question of rest. We've heard from both Dr. Broshek and Dr. Caswell that rest is very important and needed following a concussion. And why is that? Well, as we've already heard, the brain remains metabolically challenged after the concussion. There is that increased energy demand and that decreased energy flow, and which results in dysfunction at the cellular level. And that makes the brain more vulnerable to injury soon after the concussion. Therefore, it makes sense to keep people out of play, out from the athletic field, because we want to protect their head, because there's an increased risk of a second concussion during that period of vulnerability. And we know that from good studies done with NCAA athletes, done by Dr. Kevin Guskowitz, who Dr. Caswell already referred to regarding the balance testing. There's also a rare complication of having a second concussion soon after the first during this period of vulnerability known as second impact syndrome, where a second concussion can lead to severe dire consequences. Although rare, we certainly want to do our best to prevent this from ever happening to one of our student athletes. So I want to bring in a little bit science and highlight the work of Grace Griesbach, who's a concussion scientist at the University of California, Los Angeles. And she asked, is rest really important? Using an animal model of traumatic brain injury known as the fluid percussion injury. And in this, there's a hard puff of fluid that knocks the animal in the head. And she took some of these animals and she allowed some to exercise on a running wheel soon after the injury occurred, and she prevented another cohort of these animals from running on the exercise wheel for up to 6 days. And what she found is then those that were allowed to exercise, those who had free access to getting back to their daily routine, she noticed that there were decreased molecular markers of plasticity. Translating this, there were decreased evidence of those things that help us learn and remember in these rats. She also saw an increase in neuroinflammation. Now, neuroinflammation isn't always bad, but there are certainly elements of neuroinflammation that further can hurt learning and memory. And so when she looked at the whole animal level, when she tested her animals cognitively, those who were allowed to exercise during this acute phase of the injury had a worse cognitive outcome than those that were prevented from exercising. So this supports that rest really is a requirement after a concussion. But what we don't know is how much rest do our student athletes need. There was a recent study published by Thomas and colleagues in which they compared 5 days of rest to those who were just told to rest, which typically meant 1 to 2 days. And when they compared the outcome of those who were prescribed strict rest for 5 days versus those who were prescribed liberal rest for 1 to 2 days, what they found was that the strict rest group missed more school, had more daily complaints of post-concussive symptoms, and in the end there was no difference in outcome whether you did 1 to 2 days of rest or whether you followed a 5-day strict rest, almost cocooning protocol. So I think this boy here represents the problem with rest. You can see that he's pouting, has his head down, and thinking to himself, I hate rest day. And what we've learned from concluding people for prolonged periods of time is that they become socially isolated. Their parents prevent them from using the internet, playing video games, logging into their Netflix account, and texting. So they become very socially isolated. This means they have time to think about their post-concussion syndromes and worry about them. We've kept them out of school, and missing school, especially when you're a high school athlete, thinking about your AP exams and what college I'm going to, and every day you're falling further behind, leads to further worrying about your post-concussive symptoms and when it's going to get better. And indeed, we also set up parent-child conflict, because the child wants to be using their video games and their iPads and what have you, and the parent is trying to keep them away. So a problem with extended rest is that we increase stress, and we know that stress in this case can actually prevent these children and adolescents from getting better. So if we compare that last child with these children who are being allowed to exercise and all have smiley faces, we begin to see that there's an important role of some exercise as traumatic brain injury treatment. And this very busy slide is just a slide of the number of positives or benefits of physical activities on physiological functioning of the body, and examples of where exercise has been shown to have a good positive effect on health outcome. And Dr. Grace Briesbach, who I previously mentioned, chose to look at, well, what if after a little bit of rest I let some of my animals begin to exercise, and what if I keep other animals from exercising completely? And she found that after that acute phase, those animals that she allowed to begin to exercise actually had increases in the molecular markers of neuroplasticity, those markers that tell us that the cells are being allowed to learn and remember. She saw increases in those markers in those animals that were allowed to exercise versus those animals that were still prevented from exercising. She saw that oxidative damage, which is part of the cascade of things that happen in our brain after a concussion, that by allowing those animals to exercise, that they were protected from this damage. And more importantly for us as doctors and educators and neuropsychologists and athletic trainers, is that those animals that were allowed to exercise actually had cognitive improvement over those that were maintained on a rest basis. We've seen this in people as well. Majorski in 2008 noted that moderate levels of activity in humans were associated with the best outcomes. In a study of children ages 10 to 17 years with post-concussion syndrome for 4 weeks after injury, once they were allowed to begin to exercise in a supervised manner, all showed rapid improvements in their symptoms. And here is just another study done in adults where they looked at the role of exercise in those with prolonged post-concussion symptoms such as headache, dizziness, cognitive fatigue, and fuzziness. And exercise helped many of these people get back to their daily routine. So where are we today? We know that rest is certainly part of what one must do after a concussion, but how much rest and when to begin exercising are very important questions that we don't have the full answer to yet. But what is important is that what we do know about concussion is that everybody presents differently, and what one person needs in rest may be too much for another person, and the exercise that one person may be too much for another person. So as Dr. Caswell mentioned, getting over a concussion is a team sport. It requires the teachers, it requires the physician, it requires the parents. It requires so many of us to help these kids get back to where they should be, which is in the classroom and on the playing field. So with that, we're going to end the formal part of the webinar, and we do hope that you have questions, and we're most happy to answer those.
Okay, thank you very much. This is Deborah again. We did have a few questions come in. One person asked if you guys could speak a little bit to the difference in recovery from males and females who sustain a concussion, and if why there is a difference.
That's a great question. And we actually did a study here at UVA looking at high school and college athletes, and we did find that females took a little bit longer to recover and reported more symptoms, but also had more findings on objective cognitive testing. So some people have suggested that the reason females report more symptoms is that they're just more comfortable reporting symptoms and more open about that compared to males who tend to minimize or deny. But certainly our findings, which have also been replicated at other sites, have shown that females do seem to have more symptoms and do have a little bit longer period of recovery. There are lots of hypotheses about why this might be, and I don't think we really know fully yet why females may have a longer recovery. One reason that's hypothesized is that they may, with the same amount of force, they may have actually a little more force transmitted to their brain, resulting in a little bit more severe concussion, because female athletes tend not to spend as much time developing and strengthening their neck muscles as male athletes. So it may be that they don't absorb as much force, and therefore more force is transmitted to the brain. Also, there are certainly hormonal differences which have been hypothesized to play a role. And so we don't really know why it is. And so this goes back to our very important message that all concussions must be managed individually. Males and females may have different recovery curves, and different ages have different recovery curves, but there's so many individual factors that can play a role, and as long as you manage an athlete individually, then we can get them safely back to academics and athletics.
Great, thank you. We had another question for Dr. Caswell. How proficient are emergency room physicians and pediatricians, do you feel, with diagnosing concussions?
So I think what you'll see is that there is an increasing level of proficiency, but still a broad array of expertise and knowledge in the primary care setting as well as in the emergency room settings regarding a concussion. I think the concussion law in Virginia in particular and educational initiatives nationwide have been very positive in getting all practitioners up to speed on the best care for concussion. But unfortunately to date there is probably still a very broad array of knowledge and expertise depending upon which physicians you go to and what emergency room you choose.
I would add that that's not only limited to emergency room doctors, but pediatricians and sadly even neurologists. Dr. Broshek and I did a study several years ago where we sent out a survey across the country and found that practices for concussion and knowledge of concussion varied widely. I agree with Dr. Caswell that with increasing publications and attention that those gaps are closing, but with all physicians, no matter what type, we need to be very careful and make sure that they do have some understanding, and that's why in the law, Virginia state law, it clearly says healthcare providers with knowledge in concussions and education in concussion.
Okay, thank you. We had another question from school personnel. When writing policy and educating the public, should they use the term concussion or brain injury?
That's a great question, and when we're talking about sports concussion, I think our bias is to use the term concussion. Concussion generally conveys to most people that this is a transient, a temporary alteration in brain function, and we expect people to get better. While it is certainly the most mild of the injuries on the spectrum of brain injury, talking about a brain injury really implies more persisting deficits, so we really like to use the term concussion.
Okay, great. We have one more question about handling a situation in school if a student is still experiencing headaches while reading. Any suggestions on how schools could handle that situation?
So this if you think about what happens when reading, it's a good setup for those who have had a concussion to experience headaches. Your neck is down and you're putting additional strain on those muscles, as well as you're asking your eyes to converge. So in those children who are having headaches limited to reading, one, I ask them to try to prop the book up. And the other is that we do a very careful examination of the eye movements and those convergence movements, because just as we saw that there are balance difficulties after concussion, one of the other things that the brain has to balance is moving those eyes in towards the nose, and actually the part of the brain that does that is very much related to the part of the brain that lets us stand up when we're on one leg. So in those cases, we work very closely here at the University of Virginia, as do other concussion programs, with occupational therapists or vestibular therapists who can work then with the child to get their convergence eye movements back to normal. In some cases, we need to use prism glasses, but this is a common complaint and should be assessed by the neurologist or the pediatrician for problems with eye movements.
Thank you. We had another question come in about pain relievers and how to track improvements if you're using them to treat headaches.
So was the question how to track the use of pain?
How do you track improving headaches if you're using, or improving symptoms if you're using a pain reliever of some kind?
So I'm going to talk around the question because I'm not sure I fully understand it. But certainly pain relievers have a role, and tracking relies on good communication between the parents and the physician about how much is being used. I don't use narcotics or anything that could be abused on an outpatient basis with any of my patients, be it one after concussion or chronic daily headaches. The question's always been, can you go back to play if you're still on something like tricyclic antidepressant that is masking the headaches? And again, that's part of that decision that I make with the school athletic trainer, and based on an individual history of whether all we're doing is masking that post-concussion or whether it's been a long-standing problem with headaches and we're actually treating headaches. But again, tracking is open communication always between the child, adolescent, and the parents and the physician. Making decisions when to stop using those pain relievers also depends on each person, how they're doing. But I find that most people, as soon as they get back to going and feeling well, stop their pain relievers and sometimes forget to call my office to let me know. So okay. I hope that answers the question.
Thank you. One last question. How proficient are CT scans in diagnosing and treating a concussion?
CT scans don't diagnose concussion. Concussion is a clinical diagnosis. If somebody were to get a CT scan, that would be because they were worried about some other additional injury to the brain over a concussion, such as there being a subdural hemorrhage or any other type of bleeding in the brain, or CT scans are used to rule out other conditions. They don't make a diagnosis of concussion. And we want to minimize the use of CT scan in our children in adolescence, because there are good studies showing that although the risk of radiation is low, the dose of radiation is low, and the risk of future brain cancer is low, it's not zero. So CT scans should only be used on an emergent basis where the physician is worried about something other than a concussion.
Okay. Alrighty. We had one more question come in for observation post-injury. Should an individual be kept awake for several hours following the injury?
I think that was the common practice years ago, and I think that today we know that that's not entirely necessary to do. So I think it's important following a concussion that someone have an opportunity to rest, and that as long as they're not showing any signs of more significant head injury, that it is fine to allow them to rest.
Okay, great. Thank you. We had a few questions come in about a specific case or scenario, so those individuals can contact us at the Brain Injury Association of Virginia to get that information. And thank you all so much for joining us. We really appreciate it.
Thank you, and thank you to everybody who took the time out to listen to this webinar today.
Thank you.
Thank you.